Hi, our next topic is immunity. This is actually part two, and we're going to talk about HIV and AIDS, and that is exemplar 8.A in your textbook. Be sure you have your outline so that you can follow along. There's a whole lot to this HIV, especially in the book, so what I've tried to do is condense this, put it in maybe an easier to understand format to help you all out. Okay, so let's talk about HIV. So HIV stands for Human Immunodeficiency Virus. And what happens with this is the virus attacks our lymphocytes and specifically our helper T cells, and it changes the host's DNA. So you've got a longer patho written about how all this happens, but it's changing this DNA. It's been around since the 70s, and we've actually seen a lot of progress with this. I can say within the almost 40 years of my nursing career, we've really seen a big change in HIV, and that goes to really studying this for many, many, many years. So these helper T cells start the immune response, and they signal other immune cells. So what happens obviously is we have immunodeficiency and weakened immune systems, hence the name HIV. We use the CD4 count to really measure the T cells. There's lots of different kinds of T cells, lots of different kinds of like subcategories of lymphocytes, but really it's the CD4 that we're looking at that tells us about these T cells. And the lower the CD4 count, the weaker our immune system is, and we're going to look at that later under diagnostic tests. So the body does make some antibodies against this HIV protein somewhere between 6 weeks and 6 months after infection. And that is why if you're tested early, sometimes those test results may not show any antibodies. Antibodies does not mean that you're immune, because that's not how this works. The piece that's interesting with HIV is that it can be inactive or latent for many, many years, or actively start making new viruses that destroy the infected cells. So that's where it gets really kind of just tricky. So let's talk about transmission, because this is what is so important, is how this is transmitted, and this is where we need to really focus what we're doing. It is found in blood, semen, preseminal fluid, rectal fluid, vaginal secretions, breast milk, and CSF. The biggest mode of transmission is through sexual contact. Most HIV occurs in men. That's a greater than about 80%, and this is men having sex with other men. Women account for basically the rest, about 19%. It is more prevalent in our Black and Hispanic women of new cases. And for women, it's actually through heterosexual contact. Our transgender individuals are at higher risk. Children less than 13 now are rarely infected with HIV because we do better prenatal prevention than we did in the past. Adolescents are seeing a higher incidence of HIV because of early sexual activity, substance abuse, and actually low awareness of HIV risks. Our older adults, which for this, the book does specifically say 50 plus, are seeing increased rates of HIV. People are actually living longer because of our intraretroviral therapy, so ART. It's really effective in suppressing the virus and increasing life expectancy for people living with HIV. And we do see increasing occurrences in this population because they have been in decades-long monogamous relationships, so they're either divorcing or losing their spouse because of death, and are out dating and don't realize the risks of HIV, aren't used to having to have conversations about having protected sexual encounters. So we can see a rise in the older population. Okay, so let's talk about risk factors. The primary risk is behavioral. Having sex without a condom, sharing needles or other drug paraphernalia, impaired judgment, and risky sexual behaviors are all can be linked to drug abuse as well. Poverty, pregnancy, breastfeeding, older age, working in healthcare are also risk factors. Hemophilia and blood transfusions pose a very, very small risk. We may still have people alive who did contract HIV from or from blood transfusions, but we've actually been monitoring our blood products since the late 80s, early 90s, and that's just not really the case anymore. So let's talk about prevention, because this is where we really need to do a lot of work, and anything that we can prevent, we certainly want to spend a lot of time educating our populations about this. So the goal is to prevent new HIV infections and manage any opportunistic infections for those who have HIV. So our preventive strategies need to be education, counseling, behavior modifications. Those are our most effective tools. We need to use an interprofessional team approach to this. We need to think about the populations who are at risk or the populations we are educating, and think about who might be best to educate those. While as a nurse, we are all capable of providing education, but if we are speaking to people that we understand, people we live with, people in our neighborhoods, people in our civic organizations, then they're going to listen to us more than somebody who they might see as an outsider coming in telling them what to do. So that's important to think about. So what we have to talk about is safe sex practices. Really, the only safe sex practice is actually no sexual contact. Okay, we all know that. We all know that that's probably not going to happen in a lot of populations. Safer sex includes long-term mutually monogamous relationships between unaffected partners. Always use a condom. Those are male and female condoms. Every single time that you're going to have contact with vaginal, oral, or anal encounters, especially if your partner's HIV status is unknown. So this means we're going to have to teach people how to use condoms and how to put them on and take them off correctly. Avoid high-risk behaviors. Don't share needles or drug paraphernalia. Avoid unexpected sex with multiple partners. Understand the risks of high-risk sexual behavior and injecting drug use. If you have to have surgery, you can go donate your own blood for that. But as I've already spoken, our blood supply is really pretty clear. Healthcare workers. We're going to get to that in a second. I have a note on if you're HIV positive. Do not donate blood, organs, or sperm. Avoid sharing needles, razors, toothbrushes, or other personal items. Don't get a tattoo or a piercing. Avoid exchanging body fluids, sexual encounters. And inform your healthcare providers of your HIV status, which includes medical, dental, or anything else. So for healthcare workers, we are at a risk of being exposed to HIV. We're at a risk for being exposed to hepatitis and lots of other infectious disease. So this is where the CDC came out with standard precautions, that if you're going to come in contact with body fluids, put some gloves on. If you're at risk for a splash injury, then wear eye protection, wear a gown if you need to. And the reason we use standard precautions for everybody is we're treating all individuals the same. Certainly when HIV came out originally, people hid the fact that they were HIV positive. They were looked down upon, they were ridiculed, and some of that still exists. So we're going to treat everybody the same and use our standard precautions. You got to treat all body fluids as potentially infectious. Use gowns, gloves, masks as needed. Use standard precautions when caring for HIV positive mothers and infants. We won't know the infant's HIV status until after they've been discharged, so we just have to use standard precautions with them. So we now have two kind of new classifications. We have pre-exposure prophylaxis called PrEP, and this allows individuals who are currently HIV negative but who are at high risk for becoming infected with HIV to reduce their risk by taking one pill a day. And this has a greater than 99% efficacy. And these meds block the pathways that the HIV uses to set up its infection. So this is incredible that we have these new meds for people to take. So these are people who might have some high-risk behaviors, maybe having sexual encounters with those who may be HIV positive. So PrEP has really changed the situation. Post-exposure prophylaxis, or PEP, is used to prevent HIV after a possible exposure. Probably you may be most familiar with this as if a healthcare worker has maybe an accidental needle stick. So they may have been exposed to HIV through needle sticks or contact with fluid, or adults who experience, or this could be adults who experience high-risk exposure from HIV. The example the book gave was in sexual assault. This post-exposure needs to begin within 72 hours, and the meds are taken for 28 days. And follow-up appointments and HIV testing are required. We do have CDC recommendations that we are going to go through with that. So if you have an exposure to blood, body fluids, needle stick, then you contact your supervisor, follow your hospital's protocol. Patients are usually tested. They don't, that's done so that we know what their status is, and you need to start these medications within 72 hours. Okay, so let's talk about clinical manifestations. So you have, if you'll look on page 522 to 524, you have a couple of pages of clinical manifestations. You also have in your book a table that talks about the stages. So let me just talk about that. So your book does show stages 1, 2, 3, and 4. It's the only reference I can find that lists stages 1, 2, 3, and 4. And I feel that there's actually a misprint in your book on stage 4. And I'll tell you about that in just a second. So stage 1 is active HIV infection. There's a large amount of HIV in the blood, and the person is very contagious. Most patients develop flu-like symptoms within days or weeks after they've been exposed to HIV. So they can have fever, fatigue, malaise, night sweats, weight loss, dry skin, and rashes. These are often mistaken for flu-like or other viral illnesses, and people really don't think anything about it. These patients' CD4 counts are greater than 500, which is a normal CD4 count. So this happens, you get exposed, you have some flu-like symptoms, you're like, I just got a little sick, and then you don't have anything else happen. Then we move to stage 2, which is the chronic or latent HIV infection. After the initial illness, individuals may be asymptomatic or have few symptoms for somewhere between 8 to 10 years. This varies widely. You could have symptoms much sooner, but you can certainly go almost a decade without any symptoms. The HIV is still active and it is reproducing in the body, and these individuals can transmit the disease. Individuals who get treatment may never move into stage 3, which is actually AIDS. Without treatment, this stage may last a decade or longer, or may progress faster. Symptoms, if they have any, can be diarrhea, oral problems such as thrush, leukoplakia, which are white patches on the lining of the mouth or tongue, oral ulcerations, gum inflammation, weight loss, respiratory infections, herpes zoster, or nail funguses can occur. We do see the CD4 count start to decrease in this stage. Now, stage 3 is defined as acquired immunodeficiency syndrome, or AIDS. It is diagnosed when your CD4 count is less than 200 or you have an AIDS-defining condition. And these are opportunistic infections, cancers, or other health problems that occur in patients with HIV. So these are things that people with healthy immune systems do not get, and we see more in this population. So at stage 3, you have AIDS. Now, your book talks about stage 4 and just says HIV infection. I believe that's a misprint. Stage 4 would be AIDS as well, because you wouldn't have AIDS and then go back to HIV. Okay, I just listed 3 because that is what I found on CDC and several other references. So this is where we've progressed to AIDS. And with AIDS, there's more symptoms, and this will eventually lead to what causes death in a patient. So let's talk about these clinical manifestations, and these really are in conjunction with stage 3 and being AIDS. So I just gave you the stages because I wanted you to understand how it's categorized, and not so much it's stage this, it's stage that. You do need to understand what's HIV and what becomes AIDS. And AIDS is your CD4 count is less than 200, or you have these AIDS defining conditions, which are opportunistic infections, cancers, or other problems. So we can have some neurologic effects, and there is an age dementia complex, so we can kind of think back to cognition that we've talked about. The virus spreads to the brain, affecting cognition, motor, and behavior. Early symptoms are memory loss, confusion, poor concentration, slow thinking, and loss of interest in activities that you had interest in previously. Later, it causes severe dementia, motor problems, so tremors, ataxia, spasticity, incontinence, and paralysis. So we can see some significant neurological problems. Opportunistic infections. So these are infections that just don't occur in the general population. We see it with people with severe immunosuppression, specifically in HIV. So the first one is PJP pneumonia. I have seen this several times. It's the most common infection and most common cause of death, and it's caused by a common environmental fungus. Causes fever, dry cough, shortness of breath, tachypnea, severe respiratory distress, which can lead to needing to be intubated. So I've seen it several times within the ICU. These patients are very, very sick, and it's very difficult to treat this. They can get TB. It's often rapid and widespreading in AIDS patients. So you can get TB in your lungs, and you can actually have TB in other organs and other places of your body. Candidus, common fungal infection, so causing oral thrush, esophagitis, recurrent vaginal infections, so having vaginal yeast infections, often an indicator of AIDS, progression into AIDS. You can get Macrobacterium victim complex, seen with your CD counts less than 50, which is severely reduced, caused by organisms commonly found in food, water, and soil. Major causes of weight loss, so that's called wasting syndrome, fever, chills, diarrhea, weakness, night sweats, abdominal pain. Nearly every organ is affected. Other infections, herpes, so herpes simplex, herpes zoster, frequent outbreaks with that, cytomegalovirus, infecting the eyes, GI tracts, and lungs. One reference said you can get hepatitis B and C, tos, toc, toxoplasmosis. Sorry, having a brain fart. It's early in the morning when I'm recording. That's a parasitic infection of the central nervous system, causes changes in mental status, confusion, and seizures. Pelvic inflammatory disease for women, and they do require IV antibiotics. Secondary cancers, so they're getting cancers related to the fact that they are immunosuppressed from HIV and AIDS. So Kaposi sarcoma is probably the most common, presents with vascular macules, papules, or velvet lesions affecting the skin of the face, nose, ears, and visceral sites like lungs and GI tracts. These lesions are usually painless initially, but may become painful with as the disease progresses. And I did include figure 8.17 for you. If you see it on the nose, you'll actually see like a red spot on the tip of the nose or the size of the nose, and then on the earlobe. They can develop lymphomas, especially non-Hodgkin's and CNS lymphomas, and these tend to be very aggressive. And then cervical cancer develops frequently and is aggressive. Women with concurrent HIV infection and cervical cancer actually usually die from the cervical cancer because it's so aggressive. They need frequent pap smears every 6 months and aggressive treatment of that. All right, I'm going to stop this recording here and we'll come back for part 2.